Hi, my name is Bonnie Faith, and today I want to expand on the topic of post-concussive syndrome in elite athletes. Before we start, I want to review a couple of acronyms and the definition of elite athletes used in this presentation. Whenever you see PCS, I am referring to post-concussive syndrome. When I say MTBI, I am referring to a mild traumatic brain injury. And the definition of an elite athlete that I will use in this presentation is a person who is drafted in high rounds and or competes at the elite level of their sport. In my paper, Understanding Trauma, Post-Concussive Syndrome in Elite Athletes, I discussed in detail the symptomatology and comorbid conditions associated with PCS, the prevalence of PCS in the U.S., and myths regarding PCS in elite sports. Common symptoms of PCS include headaches, mood instability, issues with balance and vision, and declines in memory and attention experienced over a long period of time. Conditions commonly associated with PCS are mild neurocognitive disorder due to TBI and chronic traumatic encephalopathy, or CTE. Symptoms of mild neurocognitive disorder are loss of consciousness, post-traumatic amnesia, and disorientation. Symptoms of CTE include mood and personality changes, headaches, and slurred speech. CTE can only be diagnosed post-mortem. It is estimated that more than 3 million people in the U.S. live with debilitating cognitive impairments related to a TBI that inhibit their functional independence, productive employment, and community participation. The effects of an MTBI and PCS are misunderstood due to misinformation such as that mouthguards and helmets prevent concussions. Athletes may return to play based on a self-evaluation alone, and athletes may re-enter competition after sustaining a head injury if they do not lose consciousness. Current practices addressing PCS in elite athletes can be separated into 3 overarching categories: physical therapy, pharmaceutical therapy, and cognitive therapy. Examples of physical therapy might include exercise, manual, vestibular, vision, occupational, and sensory motor therapy. Common pharmaceuticals used to address PCS include pain relievers such as Tylenol, Advil, and Aleve, selective serotonin reuptake inhibitors such as Prozac, Zoloft, and fluoxetine, which treat depression. Effexor, a serotonin norepinephrine reuptake inhibitor, is used to treat depression. Amitriptyline, a tricyclic antidepressant, which can be used for headache treatment as well. And beta blockers, such as propranolol, to treat anxiety and or headaches. A medical professional with the appropriate training and licensure should always oversee pharmaceutical therapy. Options for cognitive therapies include cognitive behavioral therapy, stress management, relaxation therapy, and acceptance and commitment therapy. The formula to strengthen current practices aimed at addressing PCS in elite athletes involves a combination of physical, pharmaceutical, and cognitive therapies to produce one comprehensive approach. To support the collaboration of current practices, I am proposing a new framework for PCS recovery for elite athletes. At the top, a designated PCS advocate will act as the athlete's personal cheerleader, encouraging them to continue progressing through every recovery phase. This advocate should be able to step into the advocate role when the athlete is unavailable for any reason. For elite athletes, this person might be a field coach, strength and conditioning coach, athletic trainer, team physical therapist, or even a teammate. The person filling this role may change as the athlete progresses through recovery. At the second level, people will be responsible for assisting the athlete in accessing necessary resources such as testing and healthcare professionals specializing in treating PCS. While the PCS advocate may also aid in connecting the athlete to resources, two or more people will usually fill this role to increase coverage. The primary care team, compiled through the efforts of the PCS advocate, the resource person, and the athlete, will consist of the recovery team professionals who address the athlete's primary concerns. A secondary care team will typically be a brainstormed list of contact information for supplemental healthcare professionals to address less severe complications as it is convenient for the athlete. Most of the athlete support network will consist of their self-care practices and support from their friends and family. Support at the lower two levels of this approach to PCS is responsible for addressing the daily complications experienced by the athlete. Friends and family often interact with the athlete more often than their healthcare providers, so they are a significant source of support. The athlete is responsible for taking an active role in their life with PCS by utilizing their support network and the tools they provide. In one case study published in 2023, researchers explored the concussion experiences of community rugby players as part of New Zealand's concussion management pathway. The study consisted of 36 rugby players, composed of 35 men and 1 woman, with 22 competing at the primary school level and 14 at the club level. The researchers utilized thematic analysis to analyze data from semi-structured interviews. 4 themes were identified in this study. However, the theme I would like to focus on for this presentation is the role of a dedicated concussion management pathway in shaping the player's experience, which consisted of its own sub-themes, which were structured support as a positive contributor to players' concussion experience, a lack of return-to-learn protocols, and the influence of available and accessible information and knowledge regarding concussion management and recovery. Researchers noted that the athletes were overall satisfied with the support provided by the concussion management pathway. The concussion management pathway begins with educating coaches, players, referees, and family about concussions during the preseason. Baseline testing is also conducted during this time. A staff member will log the incident into an app if a concussion is suspected during training or competition. This app will email all approved parties, including the athlete, their coach, the school or club, and the provincial rugby union, regarding post-injury protocol. The player and their caregiver, if applicable, will receive an identifier code that will allow the athlete's general practitioner to access the athlete's baseline testing scores and guidelines for diagnosis and clearance. Another email is sent after an official diagnosis has been established. At this point, the athlete will be required to adhere to the return to play and learn protocols. After being cleared per the previously mentioned protocols, the athlete will be required to receive clearance from their general practitioner, upon which an email will be sent to all relevant stakeholders confirming the athlete's ability to return to training, competition, and learning. It was noted by the researchers that the study participants claimed they would have been more likely to minimize the severity and presence of symptoms without the guidance of the concussion management pathway. Athletes who have competed in well-resourced athletic programs are likely familiar with the phrase return to play protocol. This is a structured framework to guide athletes and team staff through the process of returning the athlete to competition. A lack of return-to-learn protocols often results in mismanagement of concussion symptoms, worsening the athlete's overall experience. Signs and symptoms signifying an extended return-to-learn protocol include feeling lost, trouble focusing, or headaches. Overall, the study participants found value in the information available to them regarding concussions and concussion management. The recovery guidelines described recovery goals and timelines associated with returning to competition and learning. The athletes particularly appreciated this part of the concussion management pathway. Post-concussive syndrome is not mentioned explicitly in this research study. I would be interested in incorporating data regarding the prevalence of PCS, how to decrease the risk and severity of symptoms, and options for extended return to play and learn protocols in the event of PCS into the concussion management pathway, applying it to rugby players in the U.S., and assessing the effectiveness in improving outcomes for athletes. As a social worker, I could see myself filling a few roles. As an advocate, I would actively participate in the athlete's recovery by listening to the athlete's experience and pursuing supplemental education regarding PCS and elite athletes to be prepared to fulfill my role completely. I would likely struggle to be an advocate without also accepting the responsibility of connecting the athlete to necessary resources. I intend to enter private practice as a clinical social worker post-graduation, so it is very likely that I may be a member of an athlete's primary or secondary care team. As the therapist of an athlete experiencing PCS, I would want to ensure that I establish a safety plan in the event of a crisis, design a living document to organize the athlete support network, screen for any mental health conditions, and utilize my knowledge and education of PCS to bring a trauma-informed approach to the athlete's treatment plan. My newly proposed framework for addressing PCS in elite athletes benefits other social workers in my field by creating new roles to fulfill, such as PCS advocate, resource person, and primary or secondary care team member. Social workers can use this framework to help guide the athlete through the process of curating their support network. Community care is an integral part of social work and trauma-informed care. It is also the central component of my proposed framework. Furthermore, social workers who choose to actively participate in an athlete's PCS recovery will need to pursue continuing education. Some of my personal biases that went into shaping this proposed framework for addressing PCS in elite athletes are my history of PCS as an elite athlete, my critical view of current PCS educational programs for healthcare professionals, my personal emphasis on the role of mental health in PCS recovery, and a lack of trust in current practices. Thank you so much for taking the time to watch. To conclude, I want to highlight some of the main points from this presentation. The debilitating effects of PCS are far-reaching. Myths regarding PCS result in insufficient care. Current practices focus on physical, pharmaceutical, and cognitive therapies separately. A new framework can allow for increased opportunities for both social workers and the people we support. And personal biases can be leveraged.